Good afternoon. Previously, I thank Professor Badr and congratulate this magnificent Congress. We start this roundtable with endoscopic surgery and some things, little things. We have now, I think, the third wave in the endoscopia, because some years ago, this man in 1855 started with the mirror before the zini. The history is Jaco stainless steel mirrors market in 1975 started with endoscopy, Kawasaki endoscope into relative controls. Thomason changed their life and they designed the auto endoscope and they start only for some things. Jean Magnan and the last time Livio Presutti, Daniel Marchioni, Mostafa Tabaracci are the new wave in the endoscopy of the year. The microscopy performed a very good view, not even now, good illumination, but the endoscopy permits to go there in the seat of our work. And is for that is a very good control of the hidden areas and some important pros and cons. The pros is good access to the hidden areas, extended angular view, but we have the cons also, because we need to work with one hand. You need the very good control. The bedding is not a good aid for our surgery, and you need some learning curve important. That is very important in the examination, little by little, etc. And with that, we have many procedures in the year that we perform. Learning and documentation, Reconstruction, Tympanoplasty, ossicular chain subpedial surgery, cholecystoma and retraction pockets, and implants, also in skill bad surgery to the acoustic neuroma. We have the lucky because we have a very expert table, and we ask the first one to show us, Professor Ahmed Omran, to show us the revision Stapes surgery, please.
The next place. He's not here.
Well, okay. Abdel Rahman Ghoneim endoscopic perforation Tympanoplasty.
Hello. Thank you for your being present here at the end of your day. I'll skip this slide according to the history, how the innovation was created from the loop to microscope to the primitive endoscope till the endoscope we handle it nowadays. Why I use endoscope? You have a big difference between visualization between microscope and endoscope, although most of the otolaryngology are not familiar by using single hand. But if your main training is an ENT, is a rhinology, you can handling well with the endoscope and single hand. So I always said to my juniors, start your endoscopic training inside your nose. When you are familiar how to handling instrument, how you use angle endoscope, you can go to the endoscopic ear surgery. So the training should start from the nose to the ear. Not an expert microscopic ear surgery can shift to endoscopic ear surgery. It's more easy to have your training inside the nose than shift to the endoscopic ear. And all of us know the difference between the visualization of the microscope and endoscope with a wide field illumination with a better angle and better manipulation. And you can have this nice presentation of the ossicular chain, round window niche, even the small blood vessels inside the middle ear. So, if you are dealing from water coming from your ceiling and you need to block it like we are doing in the CSF rhinorrhea, it's more easy to have a blocking of a hole in the ground. So if you start your training by how to reconstruct your skull base, you can use the same maneuver to block a small hole inside your tympanic membrane. So if you have a perforation like that, what will be my strategy? We are not depending on the meatal flap no more. We are depending upon the ossicle itself. We have our malleus here, incustapedial joint there, and the fascial recess. So if I put my cartilage disc that's harvested from the tragal cartilage under the malleus, above the incustapedial joint, I can toggle it in the fascial recess, so it's gonna be elevated upward, filling the whole cavity without any depending on the soft tissue. I use my ossicle as a main support to my graft. So I can put easily through the perforation without needing of any post-auricular incision or even having a time to have elevation my flap. This is a video demonstration how we are doing after trimming the perforation. We use always 2.7 millimeter 30-degree endoscope, and we remove all the granulation tissue, exploring our ossicles, have our controlling of the bleeding, put our harvested cartilage with perichondrium, put it below the handle of malleus, above the incustapedial joint, and any missed part can be felt by palisade cartilage later on. And we use the perichondrium dissected from the concave surface as a third layer. So we use the multi-layer technique that we use for reconstruction of the skull base to close the hole inside our tympanic membrane, and the patient has only gel foam inside his external auditory canal with no head wrapping, without anything, and he can go home after half an hour of the surgery. And here is another example that is very easy. This is unedited video, it's just running fast. We dissect and then put our graft, put it under the malleus above the incustapedial joint, make sure that the all annular and drum remnant are above the perforation, have another piece of cartilage to be put as a palisade. Then we use our perichondrium to enforce the layer below the annulus. And this is the last demonstration. This is the malleus. So whatever the size of the perforation, you can use your trager cartilage, your perichondrium to reconstruct depending on the ossicle. Put your cartilage like the puzzle to fill the whole cavity. Then have your perichondrium later to be put under the malleus, toggle it under the annulus, and you have completely reconstructed tympanic membrane perforation, independent whatever the size of the perforation. Where is the size of perforation? You can use your cartilage and perichondrium and put it without any manipulation, the soft tissue of the external auditory canal. And this video demonstration follow-up of the patient only 1 week after the surgery, after sucking of the remnant of the gel foam, that the graft is completely taken. And this is a follow-up of the patient after 1 month with complete taking of the graft. Although you don't spend much time by doing much tissue dissection, it's very easy maneuver. It can be used even in as a beginner to have our Tympanoplasty. And many publication was published to have a comparative study between these techniques, where it's named subannular techniques, and how dissecting the osseomeatal bleb, and even it has superior result than the other grafts. So it's all about visualization. If you have good visualization, you can handle the tissue better, have your own learning curve, using the endoscope easily, using one-hand technique easily, has a good result. And at the end, I wanted to invite you all to our 4th Endocardius Skull Base Congress. It will be 2 days about anterior skull base and 1 whole day about lateral skull base. And finally, thank you.
Thank you, Professor Jonas. And now we continue with Professor Kadir Serkan Orlan, transcanal endoscopic articulocystoma.
Dear Chair and dear colleagues, first of all, I would like to thank my friends, Professor Badr and Mostafa, for inviting me. It's a great pleasure to be here. My topic is the endoscopic transcanal articulocystoma. So, as you know, the endoscopes have some advantage and disadvantage in the ear surgery. So, it allows a better visualization in the middle ear structure in the same screen and less operation time, less pain. We don't need to do the mastoidectomy in order to reach the anterior or the posterior epitympanum. And we don't need the skin incision. This is the advantages. But the endoscope, you know, is a one-hand surgery and need to be experienced. Learning curve is very long. And if you need the drilling, it is not easy with using the endoscope and drilling. And sometimes drill may damage the tip of your endoscope. It's very important. There is no 3D vision compared to microscopic surgery, and bleeding is we don't like the bleeding during the endoscopic ear surgery because bleeding deteriorates your vision. When we compare the endoscopic and microscopic surgery and hearing result and the recurrence rate are similar according to literature. So here you see this is the cadaveric dissection, the middle ear structure. No. So excuse me. So here is the I prefer to use my computer, but they didn't allow me. Okay. We removed all the ossicles, and as you see, the anterior and posterior epitympanum. Here is the facial nerve, and there is the tensor fold. Tensor fold is very important for aeration of the attic area. Professor Marchioni popularized the tensor fold. If the tensor fold is closed, the attic aeration deteriorate attic aeration and may result in the retraction pocket and the cholesteatoma. Here you see the supraturbal recess and the epitympanic area. It is very easy to all the structure you can see in the same screen by using the endoscopic ear surgery. So there are four randomized controlled trials compared to endoscopic and microscopic technique. Here you see this is a 78 patient, and mean area of exposure in endoscopic articulotomy was less than the microscopic group, as you see, and the operation time is less in endoscopic technique, and postoperative pain score is also less in endoscope. This is the same result about 190 patient, and this is also the 40 patient. This is also randomized controlled trial. As you see, it is the same result. The hearing result and the success rate is the same in both groups, but the operation time, pain, and hospital stay less in the endoscopic attic surgery. Tensor fold is very important for attic area, but Professor Marchioni is classified as type A. It is the horizontal location over here. This is the horizontal location. type A. Type B is a oblique location like this. It is the green is tensor fold, and type C is a vertical location. If the close the tensor fold and it may result in the ossiculoplastoma. So in my practice, I always check the tensor fold in ossiculoplastoma surgery. So I'm going to show you the two sample cases, the ossiculoplastoma with using the transcanal endoscopic approach. Here you see on the left side, the there is a cholestoma, and pars tensa is okay, there is no problem. And also it doesn't invade the mastoid air cell. Mastoid antrum is not invaded by the cholestoma. It is localized in the epitympanic cholestoma. So here is the hearing before the surgery. This is the transcanal endoscopic approach. This is a 4 mm endoscope. 3 mm endoscope is also be used, but I can say that 4 mm, the visual quality is better for 4 mm than the 3. So we remove the cholestoma from the attic area and elevate the tympanomeatal flap with using the suction elevator. And here you see we remove the external auditory canal bone to expose the epitympanic area. Sometimes I use a cuvette and the drill. If there is a limited cholestoma in the attic region, and no need to be mastoidectomy and the skin incision in these cases, we remove the incus. Incus is invaded by the granulation tissue and the cholestoma, as you see. And hypotensive anesthesia is very important for endoscopic ear surgery. Now, the nipple doesn't work here, so in order to expose the anterior epitympanum, we need to remove the head of the malleus. So we have to remove all the cholestoma, both anterior and posterior epitympanic area. And we remove the head of the malleus. And here you'll see the anterior and posterior epitympanum clear right now. And we are checking the tensor fold. Tensor fold is closed. It is here. This is the tensor tympani tendon. It is behind the behind location, and it is closed. That's why we understand that the retraction pocket and cholestoma is due to the closed tensor fold. So the malleus was relocated to the stapes, and we put some bone cement to fix it between the two ossicles, and moving is okay. And then we put some cartilage to obliterate the epitympanum and the orifice of the antrum. And the fascia over the cartilage. Here is the second year after surgery. As you see, there is no recurrence or the residual disease because it is the opening cavity. So the hearing is the same as the preoperative audiogram. The second case is also, you can see the ossiculoplasty, and this is also transcanal approach. No need, we did not make a skin incision and endoral incision. We remove the cholesteatoma from the attic region. It is also the limited cholesteatoma cases. If the cholesteatoma invade the mastoid antrum and the massive cholesteatoma, actually we do the open technique.
Dear doctor, your time is up.
Okay, just a second, please. Okay, we remove all the epithelium from the epitympanic space and preserve the ossicular chain. We do not touch the ossicular chain. It is possible to remove all the epithelium by using the transconal endoscopic approach. Here you see there is no squamous epithelium over the ossicular chain and the epitympanum, and we close with using the cartilage. Okay, this is the third year after surgery. Here you see the healing is very good, and the hearing is also comparable to the preoperative hearing level. This is very important paper. TOS presented the recurrence rate is increasing for 8 years. That's why we have to follow the cholesteatoma case for a very long time. So I don't have a plenty of time. Take home message: endoscopic transconal attic cholesteatoma surgery as successful as the microscopic surgery, and it has a less operation time, no need to be mastoidectomy, and patients should be followed for a very long time. So we are looking forward to seeing you in the IFOS meeting in Istanbul. Thank you for your attention.
Thank you. There is Dr. Khashaba. He wants to ask a question.
Please, Mr. Chairman, I am the moderator, not you.
Yes.
Go out.
Is okay. I prefer to do this simultaneous. Yes. Because it's okay.
In my country, patients want to do the one session. So we don't have a plan of operation room. That's why we prefer to do the same session.
I think doctor,
You don't do re-exploration in 12 months.
I don't prefer to do the re-exploration because I follow with the MRI.
MRI diffusion rated.
Yes.
Well, thank you.
okay, thank you very much. Well, I think we have a little time to some little things also. I performed endoscopic ear surgery 24 years ago, but my criteria is not only endoscopy. I ask you, Professor Raman Jonas, which do you think is the apportation, the benefit of your technique in comparison with the microscope technique for this kind of approach?
When our first learning, when we was residents, always big perforation are too much challenging when we are using microscope, and we face many bleeding once we have much tissue dissection. If I go through the perforation by endoscope, there is no much tissue manipulation, and whatever the size of the perforation, it doesn't matter because I'm not depending on the soft tissue. I'm depending mainly on the ossicle and fascial recess. So whatever the size of perforation, I can block it.
Okay, but I have a comment for that, because the endoscopy permits a very good view of all the programs. Okay, that's true. You permit to check all the areas, that's true. But to put the cartilage or another, you can use the microscope. It's not the enemy, it's a complement. If you have checked, you can work with two hands. Why no?
We are primary rhinologists, so working with one hand is so easy. And with a special instrument with a suction, with a round live with suction, and all instrument is now provided with suction, so your single hand is actually double hand. And there is a much difference in the time. This operation doesn't exceed 30 minutes, but only elevation, the ostomeatal flap, and all the preparation of the ear take, I think, more than that.
Yeah, okay. Well, this is important because the endoscope can aid us in our surgery very important things, but it's a complement of the microscope. It's not only the use. It's not the question if can I do it with one hand? Yes, maybe you are very artistic, but no. The question is, what is the best for the patient? For the patient is to check, to see, and to use the most safe procedure. And I think it is important to have both systems in our operating room.
It's all about visualization. For the sake of the patient, you need to know to visualize well that you get rid of all the pathology. If I'm dealing with cholesteatoma, and I think endoscope is more superior, even in this section of cholesteatoma sac, because you are following the natural pathway of the pathology, and you get to make sure that your reconstruction is efficient, and this is better by endoscope. So for the sake of the patient, endoscope is more superior than microscope because it checks that you get rid of all the pathology, and it checks that you have efficient reconstruction and grafting of the drum. And if I cannot do endoscopic, good endoscopic tympanoplasty, I cannot use my endoscope with a drill on the other hand to have more extended surgery using endoscope. So it's always a matter of learning curve. If someone was asked me, I doing my tympanoplasty using globe 40 years ago, it was a miracle for me. So the normal innovation between the lobe monoocular microscopes and the new innovated microscope should be continued by using the angled endoscope.
Okay, thank you. And for the retraction pocket and cholesteatoma, really, the endoscope permits us the endoscopic, very good approach, very minimally invasive approach. That's true. It's really very important to have a very good diagnosis, previous diagnosis, because in some cases you have more than one focus of cholesteatoma, and you didn't know it. But I think it's a very good proposal, the minimal invasive approach to the attic cholesteatoma. But in these cases, maybe you can use not only the conventional motor, also it is possible to piezoelectric, because the piezoelectric permits us to clean the bone little by little with good view, the little region, not for big extended approach. What do you think about that?
So I don't want to say that the endoscopic approach is the best approach for the middle ear surgery. So we are the ear surgeon. We sometimes choose the microscope and sometimes choose the endoscope. Endoscope allow to access to hidden area, to expose the hidden area in the temporal bone. In my philosophy, in my practice, petrous bone cholesteatoma endoscope is a mandatory for petrous bone cholesteatoma if you preserve the hearing. So you can use the endoscope by using the microscope in the middle fossa approach, and you can preserve the hearing. And also, even you do the transaortic and transcochlear approach, you don't see the medial part of the internal carotid artery by using the microscope. You have to use the endoscope to expose there. So in active cholesteatoma, the microscope can be used in cholesteatoma. It has been for many years for many surgeons. But the endoscope can expose without touching the external auditory canal and the mastoid. If mastoid is clear, and you don't touch the mastoid. And also, your question about the tympanoplasty. Tympanoplasty can be done in microscope in all cases, but in some cases, if the perforation is anterior location, you don't see the all the margin of the perforation. You have two choices. The first one is the endoscopic approach. The second one is canalplasty. You can do the canalplasty by the microscopic approach. But the endoscope to visualize all the margin, especially in the anterior perforation.
Thank you very much. Some people in the audience want to perform some question.
Yes.
Thank you. Dr. Abdurrahman, please. ايش الايربورت
Superior uptake percentage.
Okay, thank you very much. I pass to
After permission,
هدي لا أنا كويس having nuts that with that ده Christian. That there is right. Oh, right.